Paul, did I tell you that my friend, he fell into an upholstery machine?
You may have told me this. I come in and out, Matt. Tell me more.
Yeah, it was pretty touch and go for a while, but he's fully recovered now, Paul.
Great. No, that's a new one.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cashback Memorial Hospital and its affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and America's primary care physician, maybe even the primary care physician, and maybe even the next president of the United States, Dr. Paul Nelson Williams.
Getting fluoride out of the water, getting raw milk back in the hands of babies, and honey, too. Let's just feed them honey while we're at it. Why not?
Okay, Paul, so this is a hotcakes episode, but it's Thanksgiving, or will be Thanksgiving when this comes out. I mentioned Paul might be our next president because tomorrow is election day, and we're all going to write him in on our ballots. And but Paul, can you tell people what is it that we do on the Curbsiders, and what is that we'll be doing tonight?
Sure, Matt. So as a reminder, we are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. However, this is one of our special hotcakes episodes where we go through some of the current literature and talk about our feelings, I guess. No, we critically appraise it, guided by some of our co-hosts who I'll introduce shortly, and talk about how it's going to change our practice, if at all, and then we'll give it an arbitrary ranking at the end that I think, because we're Thanksgiving themed, is going to be Tofurkey-cakes, Matt. Is that correct?
Yeah, I think Tofurkey-cakes with you can gravy and cranberry sauce. If you want to add toppings, that's fine.
Okay, fantastic. So as I alluded to, it's not just me and Watto this time around. We are joined, as per usual, by Dr. Rahul Ganatra, our critical appraisal specialist, our friend, our pal, our resident smart guy. And then we're also joined by Dr. Jen DeSalvo for the first time on air. Is that right?
That's right.
But listeners almost certainly familiar with your writings for the Curbsiders Digest, and I think you've done some videos for that as well. So we know you, but we've not seen you in this particular context, but we're excited to hear from you about your specific topic.
Thanks for having me.
We needed a fourth person, and you are exceptionally qualified, so thank you very much. And your writing has been great for the Digest, so people should check that out if they have not been reading the Digest. And let's get right into the first article, which I will be talking about. And this is an article that, Paul, I had to choose this one. This was by Rogers et al., and this appeared in The Lancet recently in 2024. And this was an article about a triple pill for hypertension. The triple pill included amlodipine, telmisartan, and indapamide. And Paul, I'm a huge fan of indapamide.
And combination pills.
Yeah, and
this
combination pills. So this was, as you said, Paul, this was like catnip. I had to read this one. So we all know that we do a poor job of controlling high blood pressure. Whether you look at a goal of 140 over 90 or 130 over 80, we're just not doing a great job. So I've been using a lot more combination pills in my practice and having more success. And patients are usually reluctant to add an extra pill, but sometimes if you put them on a combination pill, they'll get to goal. So the guidelines are now recommending a lot more use of single pill combinations of multiple agents, and there's a lot out there. There's a couple triple pills in the U.S. that I've been using. This is a new one that will now be coming out. So this was a positive trial, and what they looked at here was the once daily pill containing amlodipine, telmisartan, and indapamide, and how much it lowered home blood pressure compared to dual therapy with any combination of amlodipine, telmisartan, and indapamide. So for instance, there's a pill with amlodipine and telmisartan, or telmisartan and indapamide, and so forth. So there were four groups in total, and they randomized the patients 2 to 1 to 1 to 1, and with more patients, most of the patients being on the triple pill. So I'll pause there. Questions, concerns? Dr. Williams, can we start with you?
I guess I'd like to know, if you could tell me a little bit more sort of about the baseline of the patients that were actually enrolled in this trial, Matt. So I'm wondering, like, are there patients who've previously been on no medications that they're just sort of slapping triple therapy on? Sort of what was the process for choosing?
Yeah.
How did they sort of stratify those patients? Because I know there's a certain way that they did it that I thought was actually kind of interesting.
Well, that's a good question, Paul. So this was actually a relatively healthy group of patients overall. The exclusion criteria were pretty extensive, like patients with cardiovascular disease, CKD, people that needed 4 or more blood pressure meds were not in there, uncontrolled diabetes. So, not super real world compared to what I'm seeing in my practice. And some patients could have been on medications, some patients weren't. But that was it. What were you getting at? Something else specifically? Because this was extensive. This was like a long article, and then there was like 4 supplements to it, Paul. So I
Oh, I only read 3 of them. Oh, I'm so sorry. No, I guess that's what I was getting. I was sort of wondering what our baseline patients look like, and if, like, how hypertensive they have to be started on triple therapy at baseline, I guess, was sort of the larger question I was asking. Because it looks like I think that the patients who were not on any medications to be started on this had to start at a higher baseline blood pressure, or am I making that up?
Yeah, so Paul, I think what you're talking about is just that. So there was a active run-in phase of this trial. So initially, before they started the active run-in phase, patients had to, depending on what their blood pressure was, if they weren't on any medications yet, the blood pressure had to be higher. I don't remember the exact numbers, but the blood pressure had to be higher, which makes sense because if you're going to be putting someone on a triple pill for the active run-in phase, you want to make sure their blood pressure is high enough to tolerate it. So,
yep.
But if the patients were already on 1, 2, or 3 blood pressure medications, then then the threshold was a little bit different. But yeah, you're right. And then, so they did this 6-week active run-in phase where they were on a lower dose, not the full dose of the triple pill, just to make sure people could tolerate it. So that was, I would say, was one of the limitations of this study, because it reminds me of like the what is it, sacubitril valsartan. I think they did that in that study for heart failure. They had this run-in phase to make sure patients could tolerate it. So, Rahul, what do you think about that?
Yeah, you raise an important point about the run-in phase. And just to make sure that all of our listeners and everybody's on the same page, what a run-in period is you give everybody who's going to be in the trial the same medication, and that can be either an active medication or a placebo. And in this case, this was an active run-in. So what are the effects of that going to be? Well, the people who are not going to adhere to the trial instructions, or the people who are going to not tolerate the medication due to side effects, are going to tend to drop out and be screened out as a result of the run-in period. So you can imagine that this would be good for increasing your statistical power to detect a therapeutic effect of a medication, but this is also going to lead to systematic underestimation of adverse effects. So that's, one important thing to sort of keep in mind when you're interpreting the results of studies like this is an active run-in phase, good for statistical power, but bad for accurate estimation of adverse effects.
Yeah, and they had to look at a lot of patients. They ended up with 1,385 patients that were randomized, but they started out with like 7,000 or 8,000 patients. So it was a lot of patients that they had to use to try to get down to this.
And I think, Matt, even before randomization, you had to have adherence of 80 to 120%. I don't know what 120% adherence is, by the way. I don't know if you're taking extra pills because you like it so much. Like, I don't know what that means necessarily, but I will say that's probably higher than most non-trial patients on blood pressure medications, period. So again, it does tend to favor, like, to Rahul's point, it just seems like it's going to really select for people who tolerate the medications at their baseline.
And I think I misspoke that it was a 4-week, not a 6-week active run-in phase. But basically, everyone was getting the triple pill for that 4-week run-in phase. It was half dose of the triple pill, and then they were randomized if their blood pressure during the run-in, their systolic blood pressure had to be between 110 and 150, and they had to be able to tolerate the medication and adhere to it. So, like we're saying, they're kind of setting themselves up for success, at least with patients being able to take the medication. And then the main outcome that they were looking for, because this was done during the pandemic, they actually switched from clinic blood pressure at 12 weeks, compared to randomization. They ended up using home blood pressure at 12 weeks. And they were looking for at least a 3 millimeter mercury difference between the study drug, the triple therapy, and each of the 3 dual combinations that they studied it against. And they had a minus 2.5 difference between one of them, a minus 5.4 and a minus 4.4 millimeter mercury difference. So overall, the triple pill reduced the blood pressure compared to the other agents, and also more patients were at the goal of either like less than 135/85 or less than 130/80, depending on what you looked at the end of the 12 weeks with their home blood pressure. So like if you look at the stricter number, 46% of patients were at goal. And if you looked at the less than 135/85, it was something like 70% of patients made it to goal, which was more than each of the dual therapy groups. So as you would predict, the triple therapy lowered blood pressure more. There was a trend towards more people discontinuing the triple therapy, but it wasn't statistically significant. And then the adverse events, there was a little bit more hypotension, but not off the charts. There was a little bit more of the things you'd think about, like electrolyte abnormalities and that sort. But overall, the safety signal wasn't too concerning to me. And I've used triple pills. If you use them in the right patients that have hard to control blood pressure, this seems to go along with what I've seen in my clinical practice using the triple pills that are out there now have either olmesartan or valsartan, and they have hydrochlorothiazide and amlodipine. They don't have indapamide, Paul. So that's part of why I was so interested in this, because indapamide's a superior agent in my hands anyway.
Sure.
So and Jen, what do you think about this as a cardiology fellow? In the future in your cardiology practice, what do you think about this? The practicality of this?
Yeah, I think it's really interesting using kind of this triple combination medication. And I'd be really interested to see how it applies to other patient populations with comorbid cardiovascular disease. Kind of like you mentioned, they excluded patients with uncontrolled diabetes and renal disease. But frequently, those kind of conditions accompany hypertension. So I'd be really interested to kind of see how this further applies to other patient populations as well.
Yeah, so I guess to conclude, this study was a positive trial. Definitely, they set themselves up for success. So I would weight the importance of it a little bit less because of that. But I think the safety, when you're carefully selecting patients, it seems like safety-wise, this is reasonably safe. And in my clinical experience, I wouldn't be afraid to prescribe this to patients based on other triple pills that I've prescribed. So I give this, Paul, 3.5 Tofurkey-cakes, no toppings, and that's it. So we should move on to the next article, also about blood pressure. Paul, can you introduce it? And is no acronym for this one, huh? I don't think mine didn't have a good acronym either.
No, ARMS.
So.
It's ARMS, buddy. Yeah.
ARMS. Oh, okay.
So this is from Liu et al. In JAMA Internal Medicine. This is arm position and blood pressure readings, the ARMS crossover randomized clinical trial. This actually got some traction in the popular press too, that apparently arm position matters when you're measuring blood pressure is the takeaway point for this. But basically, the whole point of this paper is that as we get these updated guidelines for hypertension, diagnosing it correctly and measuring blood pressure becomes more and more important. And these guidelines tend to emphasize more and more proper positioning and proper blood pressure measurement. And these things don't always translate to the actual clinical setting. And so their specific question is on arm position specifically. We've looked at other things like patient supine and that kind of stuff. There's a study that looked at like the 11 things you're supposed to do from positioning, and we do on average like 4 of them right. But in any case, they looked at just arm positioning for this one. So they looked at this one thing that is commonly variable. And what is recommended when you're measuring your blood pressure, Matt, is to have the arm resting on it. I don't know why they specify a desk necessarily, but they lean into the desk thing. But anyway, some sort of flat surface with the mid-cuff at heart level, that is proper positioning of the patient. And they compared that to actually arm dangling down by the side, which I see all the time, or arm sitting in lap, which feels a little bit less egregious, but also very, very common, but is not according to Hoyle. So they wanted to see if those variations in position from the baseline from the correct positioning of the arm resting had any actual kind of impact on blood pressure measurement.
It has to be a desk, Paul. It can't be a credenza or an armoire or anything.
Yeah, usually it's me holding the patient's arm and saying, relax, relax, relax your arm, which nothing makes patients relax more than me screaming relax at them, by the way.
It is a problem, though, because most, Dr. Jordy Cohen, our hypertension expert that's been on the show several times, she always mentions the casual office blood pressure like a lot of patients, their legs are like dangling on the exam table. There's nowhere to rest the arm. They're using like a cuff that, like a manual cuff that hasn't been calibrated in 10 years, and it's probably not even accurate anyway. So what you measure matters, and how you measure it matters, and that's borne out in all the trials we've covered. Remember the arm one, Paul? If the cuff is 2 sizes too small, it raises the blood pressure like 20 points.
Yes. Yeah. So this is right. And especially since Matt Watto is going to be throwing triple therapy at everyone with high blood pressure, it really behooves us to have an accurate blood pressure measurement, just to make sure we're not sending them screaming to hyperkalemia unnecessarily. No. So, right. And that's why truly why this study is important, because this is such a common prevalent thing. It is one of the most, it's like the number one reversible cause of cardiovascular mortality is untreated high blood pressure or undertreated high blood pressure. So it matters that we actually get the numbers right. So the question you might be asking yourself is, was this a positive study? And I feel like I gave away the lead. Yes, it was. Like it matters where your arm is when you're actually measuring the blood pressure. And these aren't huge numbers necessarily, but if your arm is sitting in your lap at your side, it is statistically higher than if it's resting at heart level on a desk. So the arm positioning matters. The way they did this, Matt, it was kind of neat. They had 133 participants. They did these triplicate blood pressure readings with the arms and sort of randomly chose the order of the positions that they measured them. So one was done on the desk, couldn't be anything else. One was done by the side, one was done in the lap. And then they did desk last for everybody, just to have sort of this baseline comparator, and then compared the means of these measurements with each other. They actually looked at the difference in differences. So because there is some intrinsic variability in blood pressure measurement, they actually compared the difference between the two desk readings and then compared that between the non-standard positions to see what the differences were, if that makes sense. So again, the numbers were not wildly high, but like anywhere between like 4 and 6 millimeters of mercury higher if your arm was not at the correct positioning. And the techniques, like these were measured with validated blood pressure cuffs. They were trained staff. The patients were positioned properly. The feet were flat. The back was supported. The arms were at the side. They were not supposed to speak to the staff. They were not hilariously supposed to be on the cell phones during that time. And then in between the position changes, they take the cuff off. The patients would walk for 2 minutes and then sit quietly for 5 minutes before they did the whole thing all over again. So they really did their best to kind of minimize any kind of variation that was not just the arm stuff. So I thought it was really well designed from that standpoint. I would like to hear Rahul comment on some of the study design in terms of the randomization, because they mentioned specifically they used, I guess, one Excel command that was supposed to randomize things that just sort of fell apart. And do we think that matters?
Yeah, I feel like this is a little cruel. I'm not going to, judge anybody for their analytic choices. You use the tools that are available to you. That being said, Excel is probably not the best tool to use for a study like this. There is a sentence in the methods that I just thought was so honest, and I just had to chuckle when I read it. They didn't realize that using this randomized function in Excel would not allow them to ensure that there were comparable numbers of patients between groups. And the way that they said it was exploration of the Excel function ran between revealed that this program did not have the capability of assigning equal numbers of participants to each assignment. Thus, the allocation tables developed and using during randomization were unequal. Whoops. I will say, even though we're kind of giggling about it, it's still, I think, okay, because, the point of randomization is to balance known and unknown confounders, things that could be associated with both the exposure and the outcome. But in a crossover study, you have the benefit of everyone acting as their own control. And I don't have a reason to suspect that there should be any carryover effect from one blood pressure measurement position to another. So even though it's kind of funny that randomization didn't work in this study, I actually don't think that that's a big threat to these authors' conclusions. So next time, don't use Excel, but in this case, probably okay.
Right, because if I remember correctly, the randomization that they were doing was to the order at which they measured the various blood pressures in. So whether it was sort of desk to arm to lap to desk to or that. So it seems like not the least important. I don't want to minimize it, but also like it does not seem like it would significantly impact the outcomes.
Agreed. Even though the mean differences were not overwhelmingly large, as you pointed out, Paul, there were some individual patients, which they show very nicely in the supplement, who did have much larger deviations from, the 6.5, 4.5 millimeters of mercury. So on an individual level, arm position could have a large effect on measurements in blood pressure.
Right. Yeah. One of the subgroups most affected by the positioning were patients who actually had elevated blood pressure. So again, this is like, these are the people we might be treating anyway. And so that it's an important note to make.
Yeah. And I mean, even 6 points is enough that you might think about adding another another agent, like maybe if depending on what your threshold is, that could easily put somebody into the zone where you're like, oh boy, this I think I'm gonna have to add more medication.
I mean, if they're seeing you, they're going for renal denervation therapy, probably. Yeah.
Yeah. So Paul, what is your final judgment here, and how many Tofurkey-cakes?
Yeah, no, I mean, this is polycatnip. Like, this is right up my alley. I love what they did. It was a nice, straightforward study. I could understand exactly what they did, and I think it's really clinically relevant. So I would hesitate to call it landmark, but I am going to give it a 4 out of 5 just because it is just so relevant to everyday care for a very prevalent condition. And I'm going to give it 4 out of 5 Tofurkey-cakes. I'm even going to give it a little bit of gravy just because I love it that much.
Okay. Rahul, tell us about early TAVR. Should I just recommend TAVR for all my asymptomatic patients with aortic stenosis?
Well, Matt, what a question. Okay, party people, let's talk turkey. So this is the early TAVR trial by Philippe Généreux and colleagues, and this was published in an October 2024 issue of the New England Journal of Medicine. So the research question that these authors wanted to address was among low-risk patients with asymptomatic severe aortic stenosis, okay, does early TAVR reduce death, stroke, or cardiovascular hospitalizations compared with clinical surveillance? And you might be wondering, why is this study important? Well, it's because the burden of severe aortic stenosis in the United States is really high. The incidence is thought to be on the order of 50 cases per 100,000 patient years, and the prevalence of severe aortic stenosis in people over 75 is on the order of 3.5%. So this is common. And current guidelines recommend intervention with replacement for patients with severe AS and either symptoms, an EF less than 50, a positive stress test, or some other indication for cardiac surgery. Like if you're doing a CABG and they have severe AS, you should just go in and fix the valve anyway. But whether asymptomatic patients might benefit from earlier valve replacement is really unknown. So I'll bury the lead and tell you the top line findings. What did the authors find? Well, this was a positive study. Over a median follow-up of 3.8 years, compared with clinical surveillance alone, patients who were randomized to early TAVR experienced an 18.5% absolute risk reduction or a 50% relative risk reduction in a composite outcome of death, stroke, or unplanned cardiovascular hospitalization. So that sounds pretty amazing. I will just point out that this difference was entirely driven by a 20% absolute risk reduction in cardiovascular hospitalizations, which is an outcome that included conversion to TAVR within 6 months in the surveillance group. And there was really no difference in stroke or death. So can I get some initial reactions from the group? What do people think?
Yeah, I think that last point really surprised me. The majority of patients that were randomized to clinical surveillance undergoing aortic valve replacement during their follow-up. I think that was the piece, that really surprised me overall, and something that was included in really one of their primary outcomes.
Yeah, and Jen, we were talking a little bit before recording. Does this natural history of aortic stenosis in the surveillance group, does that conform to what you see in the clinic and on the wards, or does this seem like a lot of people getting converted in the surveillance group?
Yeah, it seemed pretty quick to me, kind of overall, just given that the majority of patients that were converted to actually receive a TAVR in the clinical surveillance group really underwent that within, I think it was a median of 11 months or so. And, we kind of talked about potentially that was because they already worked up for a TAVR and underwent that workup overall, and then were really closely monitored more frequently maybe than would be seen clinically out in the real world. And so that maybe that process of easily being able to get a TAVR once symptoms developed with really that close follow-up kind of led to that finding as well.
Yeah, I thought that was funny. The authors kind of said in the paper that, yeah, it might have been the fact that we pretty much did all the anatomical planning and had everything ready to go, that may be why so many people converted so quickly over to the TAVR group. But Paul, I mean, just having that be one of the endpoints, maybe if they had it emergent, new heart failure or acute admission, need for valve replacement surgery, something like that, that would have seemed more of a valid endpoint. But this was just we just decided to pull them over and replace their valve.
Yeah, it felt very Schrodinger's cat to me because paying attention, you just have to wonder the impact of asking, are you having chest pain? Have you had any syncopal events? You have any signs? You just sort of being asked and sort of being more looking for symptoms, because really the symptoms are the reason to actually make the conversion in the first place. Like you just wonder how much more the close attention actually resulted in driving sort of the conversion in this particular group.
Well, you're all such natural skeptics. I don't think anything in the trial specifics are going to really inform your appraisal. But I'll just tell you that in order to round out the information, the way that they actually carried out this study, patients at 75 sites in the US and Canada were randomized 1-to-1 to either undergo early transfemoral TAVR with an Edwards SAPIEN 3 valve or clinical surveillance alone, which basically consisted of follow-up visits starting every 6 months. And one strength of this study was that asymptomatic status was confirmed in like 90% of patients with a negative treadmill stress test. So tells you a little bit about the study population here. So who are the patients? Well, the trial included a little over 900 patients with a mean age of 76. Essentially, everybody was white, and everybody had quite low surgical risk. The predicted 30-day post-op mortality via the STS risk score was 1.8%. Mean LV ejection fraction was in the high 60s. Everybody had to have severe AS and anatomy favorable for TAVR, kind of getting to the point Jen raised about everyone, being surveilled and having all the workup done already. And these were generally lower risk patients since most of them were able to perform a treadmill stress test.
It's kind of remarkable. This is not the patient group I think about with severe aortic stenosis that they're sort of, doing Bruce stage 10 and, have, an EF of greater than 60%. Like this is just, it's like, as you say, it seems just like for a fairly healthy group here.
Yeah, they had a relatively low number of cardiac comorbidities. I was kind of surprised overall.
Yeah. So you've all telegraphed my thoughts on this, but the major source of bias towards this being a positive study is, in my mind, the definition of the primary outcome as including conversion to TAVR within 6 months as an unplanned cardiovascular hospitalization. So just it's worth, looking at the components of the composite endpoint, and we see there's no difference in death or stroke. The secondary endpoints kind of conform to that. There's no difference in disabling stroke, new atrial fibrillation, or reductions in LV ejection fraction. There were two outcomes that, if you were really trying to squint and find a positive or a reason to do an early TAVR that were a little suggestive. One was that patients who had early TAVR had somewhat greater symptom reduction at 2 years. But the assessment of symptoms is really challenging in an open label trial. And then the other secondary outcome that caught my eye was there was an improvement in echocardiographic surrogates of left ventricular and left atrial health. But there's evidence that adverse myocardial remodeling in aortic stenosis is often reversible after TAVR. So I'm not sure how excited to be about a surrogate endpoint in the absence of any clear patient-centered benefit.
Paul, before we get to take-home points, any comment on the trial name?
Yeah, it's bad, Matt. It's abysmal, I would describe it. I don't know how you can torture those letters to spell out early TAVR. Why are we pretending this is an acronym when clearly it's not? Like, just call it early TAVR rather than trying to pretend like the letters actually stand for something, because it's absurd. So shame is what I would say.
I think you should just be able to name a trial whatever you want. It can be loosely related to the actual words in the title, and that's it. Let's just call it a day.
No, I mean, I don't think you should perform the trial unless you come up with an appropriate acronym. Otherwise, I don't even think the thing should be studied, to be honest with you.
Especially a cardiology trial.
Yeah, 1,000,000%. We have plenty of cardiology trials. Like, do we really need more unless they're well named?
Yeah. What was the one?
We still haven't figured out aspirin dosing.
The SPANK trial, that was the anal cancer one. That one, they did a good job with their acronym.
Yep.
We covered that a while back. Yeah.
Pickles trial. I mean, there's plenty of great trial names out there. Like, we've not run out of options.
Okay. Well, Rahul, what are your take-home points for this, and how many Tofurkey-cakes do you give it?
Yeah. I mean, I think if we're not persuaded that the results of this trial suggest that early TAVR is beneficial, if nothing else, it's a useful reminder that the natural history of severe aortic stenosis is to progress. And so for me, to me, this suggests that early TAVR in asymptomatic patients is probably safe. There was really not a signal for an increase in stroke, which is one thing I'd be worried about. So it may be reasonable in low-risk patients, but it's not really clear to me from this trial that it improves any patient-centered outcomes compared with just waiting until an indication for valve replacement develops. So I'm really not swayed by these results. I am going to give this 2 out of 5 Tofurkey croquettes.
Okay. All right. And Jen, we have one more study to go through, and this is on transfusions after brain injury. So please, can you introduce the study? Tell us why you thought this one was important.
Yeah, absolutely. So I reviewed the TRAIN randomized controlled trial or transfusion strategies in acute brain injured patients by Takone et al. Published in JAMA recently last month. And the authors really sought to investigate how to compare restrictive versus a liberal blood transfusion strategy and how that really impacts neurologic outcomes among patients with acute brain injury and anemia admitted to the ICU at 180 days after they randomized these patients. The study was really important because anemia may cause injury to brain tissue specifically by reducing oxygen delivery and has been associated with worse outcomes in patients with acute brain injury overall. But there hasn't really been a good optimal transfusion strategy that's been established in this patient population. Just given that previous studies in this population have failed to really demonstrate a significant difference in neurologic outcomes between the liberal and restrictive transfusion strategies. Recently, this was studied in the HEMOTION trial, or the hemoglobin transfusion threshold and traumatic brain optimization randomized controlled trial that was recently published in New England Journal of Medicine. And they found a non-significant difference and kind of in favor of liberal transfusion strategies over restrictive transfusion strategies, but the patient population was a little bit different than what was studied here. And then to kind of give away the top line results, this trial was a positive trial overall. Really demonstrated that in critically ill patients with acute brain injury and anemia that were randomized to a liberal transfusion strategy overall had significantly lower unfavorable neurologic outcomes compared to those in the restrictive arm at 180 days after randomization. And interestingly, additionally, the authors noted a decreased frequency of cerebral ischemic events in the liberal compared to the restrictive transfusion strategy overall as well. Any kind of initial thoughts on this study?
Yeah, I don't see many patients with brain injury, at least not in the acute setting where they're super sick. But I thought reading about some of the physiology of it, one of the editorials was just talking about how autoregulation of blood flow to the brain can be messed up in patients who have a brain injury. So that's why just having oxygen carrying capacity and having enough hemoglobin is so important. So the pulse, like keeping their oxygen levels high and making sure they have enough blood to carry the oxygen is important. So that's theoretically where this came from, because I had not really thought about transfusion being important for brain injury. Like it made sense to me for MI. I guess this is a similar thing, but I just hadn't thought about it with traumatic brain injury. Rahul, how about as far as the setup of the study, the trial, anything there that you thought led to this being a positive trial? Any sources of chance or bias is what I meant to say.
Yeah, I mean, always valuable questions when we're interpreting and appraising a positive study. So the primary outcome in this study, as we talked about a little bit before recording, was not just mortality. It also included some measure of neurologic function at the end of the study. So, I mean, yeah, that definition kind of opens the door to an important source of bias, which is the possibility of confounding based on baseline prognosis. Patients who had much more severe acute brain injury at enrollment, could have done, I would expect, to do worse. And so disaggregating the impact of the transfusion strategy from the impact of someone's initial prognosis is really important. So in the HEMOTION study, which you mentioned, they accounted for differences in neuroprognostication at baseline using a sophisticated method that was really kind of out of my wheelhouse. But in this study, there was not any accounting for baseline neuroprognostication. So that's one source of potential confounding. That is a testable hypothesis. And, I'm kind of racking my brain to figure out how to reconcile the results of this trial with HEMOTION. So that's one source of bias that I identified, but not really sure how to put it all together.
And Jen, this study looked at patients with like mixed brain injury, right? There was traumatic brain injury, or they could have had intracranial bleeding. Is there any concern with the authors, or is there are they looking into this in just people with just bleeds to see if it's the same as people that have traumatic brain injury?
Yeah, there's actually an ongoing study right now that hopefully will provide additional evidence to guide transfusion, specifically within patients with subarachnoid hemorrhage. That's a Sahara trial that's ongoing right now. So hopefully that provides a little bit more guidance and kind of various populations within this acute brain injury.
Yeah. Yeah. And the HeMotion trial, Rahul, I think that one just had patients with traumatic brain injury, not with bleeds. So that was a little different in the patient population as well from this one. All right. If there's no other comments on this, Jen, do you have take-home points, and what do you think people should do with this for their practice?
Yeah, I've kind of thought that even though there was no mortality difference observed between the two groups, I might sway a little bit more towards transfusing those more liberally in this patient population, but really look forward to additional studies kind of ongoing as well. So overall, my hotcakes rating was 4 out of 5 Tofurkey-cakes. Maybe a little bit of mashed potatoes and gravy on the side.
Nice. Well done. All right. So to round out the show, we wanted to just mention that there are some new perioperative medicine guidelines, and we'll be doing a full episode on that at some point in early 2025. But Rahul, any highlights you wanted to point out? I took a look at these as well, but wanted to know your thoughts as a hospital medicine guru.
Yeah. I mean, for all those of you out there who are also eagerly awaiting the update episode we're going to do on this, here's something just to tide you over until then. So the ACC-AHA Joint Committee just published new guidelines for perioperative management of patients undergoing non-cardiac surgery. And the last time these guidelines were updated was 10 years ago. So we were due. And in addition to risk assessment, the update covers a lot of topics, diagnostic testing, the role of stress testing, management of medications, including DOACs. And there's a new kind of flowchart figure that I'm just imagining is going to be printed out and, stapled to the wall in resident workrooms across the country. But I'll share with you some of the highlights of that. So assuming a surgery is not an emergency and patients are not having acute coronary syndrome or decompensated heart failure, the guidelines say you should continue to use validated risk calculators to identify patients at higher risk. And for patients at higher risk, they now recommend you should use the Duke Activity Status Index, or DASI, to assess their functional capabilities. And for patients with poor or unclear functional capacity, they say it's reasonable to measure a pre-op BNP if further testing might affect decision-making. And they also talk about troponins being a reasonable alternative for that, but with kind of a weaker evidence base. I'm curious, have any of you, measured preoperative BNPs or troponins in patients that you're thinking about risk stratifying for non-cardiac surgery?
I have a pathological fear of outpatient troponins in general. So I just, if I'm checking a trope, it's not from my primary care office, generally speaking. And I still, I don't want to get the panic lab phone call and not know what to do with it. So this has not been something I've incorporated into my practice as of yet.
Sounds like an on-call fellow's
That's
nightmare.
Fair.
Exactly right.
That's fair.
I didn't think
even
about
think
this
that.
being an outpatient. I feel like in inpatients, I was, yeah, sure, I'll order a pre-op troponin and inpatient, but it has not been part of my practice. I know it's been the Canadian guidelines. I want to say since like 2017 or something. At least several years, it's been in the Canadian guidelines to check the BNP. And I think part of why they're saying to check troponins now is because this MI after non-cardiac surgery, or MINS, whatever the acronym is, those people have worse prognosis even when you look out like 1 year. So we do have to take it seriously and we have to treat that. So I think they're just trying to find these people rather than miss all these silent MIs that are occurring. But I do have to say it makes me nervous, Paul. Like what are we going to do exactly with this? And the guideline, so I'm sure we'll go into this in detail with our expert when we're covering this on the show in the near future. But yeah, I think it's something I will start doing if it's in guidelines and people are recommending it, and if I'm convinced it can help patients, then I will do it.
Yeah, the language is soft, so I'm looking forward to a little bit more concrete guidance in terms of this. Can consider it, because that also the other thing that I think is relatively new and kind of neat, but I'm also not quite sure how to actualize the incorporation of frailty into the assessment as well. So if someone is frail, okay, they're probably going to do worse. But does that? So what?
Yeah.
What does it? Do I do preoperative physical therapy? Like, what does that mean necessarily? And sort of how do I help use that to optimize patients. And I'm still not fully clear on that. But
Right.
to be fair, I have not delved entirely into the 176-page guideline just yet. I've just kind of done the quick read.
Paul, how dare you?
I'm lazy is the long and the short of it, Rahul.
Yeah, I mean, there's so much to say about these, but I'll just scoot to the bottom line because, this is just a hot take. But these guidelines are important because they address the role of biomarkers in risk stratification, both before and after surgery. They also kind of suggest a de-emphasis on stress testing in most patients. They, really highlight that you should really only be thinking about stress testing in patients at elevated risk with poor or unknown functional capacity, and who have an indication for stress testing independent of the planned surgery, which is kind of a change from our practice before this. There's recommendations about medications that listeners can wait to hear in the full episode. But I'm hoping that these guidelines will result in a more judicious use of preoperative stress testing, given the absence of clear evidence that practice improves outcomes. So stay tuned.
Yeah, I can't wait to do this episode because there is really a lot of good stuff. They talked about holding SGLT2 inhibitors for 3 to 4 days prior to surgery. And, there's, I don't think there was too much change at all about bridging. I think that seems pretty similar, but we'll see. And then they did talk about AFib, not ignoring it and sort of assessing patients' risk because recurrence rates are high. And so I think that, that's something that practice seems to be evolving now, Paul, right? Because we used to be like, oh, you get a free pass if you have AFib in the hospital. It's like, oh yeah,
right. We know what the trigger was. No problem. You'll get better. Yeah.
So I think now we're moving towards like, nope, those people might need rhythm control and they might need anticoagulation. We got to assess their risk. So yeah,
there's explicit ACE and R management stuff. There's a lot of good stuff to unpack. It's going to be a great episode.
Yeah. All right. Well, with that tease, I think we should get to an outro, Paul.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Great. I like that one for some reason. Still hungry for more? Join our Patreon and get all of our episodes ad-free, plus twice monthly bonus episodes at patreon.com/Curbsiders. You can find our show notes at thecurbsiders.com and sign up for our mailing list to get our weekly show notes in your inbox. This includes our Curbsiders Digest, which recaps the latest practice-changing articles, guidelines, and news in internal medicine.
And we're committed to high-value, practice-changing knowledge, and we want your feedback, so please email us at askcurbsiders@gmail.com. It also helps a lot when you subscribe, rate, and review the show. Give us 5 stars. Come on. Paul's a clean boy. Wash your own damn sheets.
I don't like that. What?
Anyway, reminder that this and most episodes are available for CME credit for all health professionals through VCU at curbsiders.vcuhealth.org. A special thanks to our writers and producers for this episode, all the wonderful people who were speaking tonight, Rahul Ganatra, Paul Williams, Jen DeSalvo, and to our whole Curbsiders team. Our technical production is done by Podpace. Elizabeth Proto does our social media. Jen Watto runs our Patreon. Krista Chumenchu moderates our Discord. Stuart Brigham composed our theme music. And with all that, until next time, I have been Dr. Matthew Frank Watto.
I've been Dr. Jen DeSalvo.
I've been Dr. Rahul Ganatra.
And as always, remain Dr. Paul Nelson Williams. Thank you and goodbye.